We have to. Why can't y'all? Okay, so we're already rolling with the punches this morning, but we're flexible people by now, right? So we can figure this out. So Dr. Bailey is having some trouble getting here, and she's supposed to lecture after me. So if she's not here when I'm done doing our introduction, we're all going to go and start all over again. We're going to find the reset button. No, we're going to go and we're going to flip-flop things. So y'all are going to go. Tell who in here has even spent 2 seconds looking at the notes that are on there? A few? Oh, I take it back. Okay, so if she's not here yet, then the best way we think to utilize your time is to flip-flop. Mr. Freed is going to lecture to you. Okay, in the meantime, she's on her way. We'll see what happens. Okay, so happy first day of class. All right, so I'm going to do our orientation for Adult 2. Okay. So I think that last semester, I know that you all talk. And I know what you've heard about this class. It just depends on, so every couple of semesters we trade back and forth between the most hated class of Senior 1 between us and Child Health. And I think Child Health won that prize last semester. So you might have heard less bad things about this course. Maybe. But I think that as a general rule, this class has a certain reputation. But what I would like to propose is that this semester in general is a little bit of cruel and unusual punishment. Okay, 3 clinical courses is a lot. You have to not only figure out how to leave your neighborhood in the right way based on what clinical course you're going to, but do you get to wear fun scrubs, or do you have to wear, are y'all wearing the maroon ones, or are you still the white ones?
No, we're going to be the last ones to wear one.
So you're gray scrubs because you're 3rd semester, so they're not white anymore, they're gray, okay? And whether or not you're allowed to wake up your patient or not, because, you know, you let kids sleep, but if you don't wake your patients up, your adult patients up, okay? So we understand that there's a lot going on. You're going to be completely and totally disoriented until you finally get to go to the hospital and have a routine. Pardon me. So, there we go. All right. So y'all are going to figure out what's going on about week 4. The reason I'm saying this is not to scare you, but to tell you that we understand this. We understand your plight, and we are going to do our best to put information, to plop down all of the information where you can go back and find it again, so when you're confused and disoriented, you can find it. Okay? Your faculty will also, yes?
Want me to go start?
See, we all have it. All right, so this semester in Adult 2, we are going to challenge you to take all of your little pockets of information that you've learned up until this point in time. You have piles. Piles and piles and piles of information that have nothing to do with anything else. Right? That's okay. We know this. We understand this. This is the progression. We want you all to start to work on making connections with your piles. You know so much more than you think you do. The problem is you don't know how to connect them yet. And that is part of our job, is to bring you along in the process of figuring out how to make the pieces fit. Okay. It's not all going to happen overnight. It's going to be a growth process. But by the time you finish this semester, you are going to be able to take care of or supervise the care of complex patients and be able to put this all together, okay? Promise. Some of y'all are looking at me like I'm insane, but it's no different than it was last time you looked at me, so it's fine. I'm comfortable with this. Okay, So I'm going to go over just the big points in the course, just so you all have an idea of what our expectations are. If you are at UT Southwestern this semester, you either have Ms. Ajani or Dr. Bailey. If you are at Parkland or Medical City, Dallas, you have our lovely Mr. Freed. Ms. Kirkpatrick is going to take people to Methodist. Ms. Lucas and Sebastian are your VA section. I go to Presby Dallas. Ms. Montgomery goes to Medical Center Plano, Med City, Plano. I'm never going to get that. With Ms. Spadaccini, and then Ms. Sheldon has our Soul Saturday group at Bumsey. So this is our team. You see there are a lot of people. I am your course manager, so if you have a hard time getting in touch with any of your people, y'all can come to me, okay? As far as all of our adjunct faculty, as with most of your other courses that you're used to, you will have a full-time faculty assigned to you. So if you have any problems getting in touch with that person, you can go either to your full-time faculty who's assigned or to myself. If you have an adjunct faculty, you will meet with your assigned full-time member of the team to do your test reviews and things of that nature. That's in the syllabus. I will remind you of that after our first test, because you're not going to have any recollection of this conversation at all by then. Okay. Peer tutoring. This is not a new thing for y'all. Y'all are comfortable with peer tutoring. We had a little bit of a snafu with the Blackboard upgrade, which made us not able to add anybody additional to our Blackboard courses, but I believe now that all of our tutors are part of the courses. So if you haven't heard from them yet, that's probably why, because it's been a bumpy little road for them for a couple days. Our tutor for this course is Michaela Murphy. I think she posted something already, so you have heard from her, so that's good. I understand that peer tutoring, that y'all are in, like, y'all put in these huge, long, arduous days of sitting on your backsides, okay? So y'all obviously need to decide where you want to go. As far as the notes are concerned, this is nothing new as well. If there's all of the peer tutors should be showing the notes to course faculty before they give you anything. That being said, there still might be discrepancies. The other thing is the peer tutors are going to fix any discrepancies that they heard as students, because, I mean, so it's kind of a self-fixing problem. But the thing that I do want to say about any peer tutoring notes or notes from last semester that you might have gotten from somebody else, okay, this happens too, I know this, okay? If you get wrong information, it's not our problem, okay? I would like to hear if there's incorrect information from the peer tutor notes so that we can complete that and fix that. But things change from semester to semester, and I understand that if you think that you're getting information from somebody who's taken the class before, that could be really helpful because they know what's important. That's fine, okay? But you need to make sure that you're doing that with the knowledge and understanding that there could be inaccuracies in that information, and course notes are the final say, okay? But like I said, keep that information coming back around to us so that we can try to help that process, okay? But in test review and things like that, if we hear, but that's not what the tutor said, or that's not what the tutor note said, or that's not what the note said that I got from somebody last semester, sorry, okay? All right. So the course in Blackboard looks the same as everything else. All of the med-surg courses at least should be set up similar. You can do the tour of the course if you want, but it's just going to take you through where everything is. And I think that at your third semester, you're able to do that. Okay. Syllabus and schedule is current as of now, so y'all can pull that down if you haven't yet. This right here, this ask a question is going to take you into this similar type of thing that we used in pharmacology. If you remember this, you can ask a question. So you could ask questions about the course, or you can ask questions about the course content. You can subscribe to that discussion board if you want to know what's going on, and we can use that. I've already subscribed, so I'll get an email anytime anybody posts to it. If somebody asks a question about the course and you know the answer, feel free to jump in. Y'all can teach each other as well or better than we can because we kind of have one stock way of explaining something, and if somebody else has a different way of explaining something, why shouldn't we facilitate that learning? Okay, so y'all are more than welcome to jump in, but we are going to use that in the course as well. And then what else is here? Math tests. Math tests are going to start, will start tomorrow. Okay. It'll come out. It's better, we have learned that it's better to look at the whites of your eyes before we put out sign-up sheets because chaos and mayhem ensues after that, and I get an inbox full of panicked emails. So it's easier for us to tell you, then I'll go up into my office, I'll release it, and then y'all will know. Okay, so that'll come. But the first attempt will happen this week, and then after tomorrow, I will put up the sign up for the second attempt because I don't want people signing up for a second attempt if you don't need it, because then you're taking up a spot that somebody else could take. Okay, so we're trying to streamline the process. Trying would be the operative word in that. Okay, pharmacology test, we'll talk more about that later. That's an open book, open note thing that you just have to do. Okay, preferably with your own brain, not with your friend's brains. Okay, poster project. So poster project is going to be a voluntary project that you will do with your clinical group. Okay. So the people that you have that are available to participate in this with you are your clinical group, but not everybody has to participate. Last semester was the first semester ever that I can remember. We had one person in a group do it. She was the only one that wanted to participate, so she did it all by her lonesome. I'd been like, I'm out. No. But she did. Okay. So this needs to be a nursing-based problem that happens in critical care areas. So my suggestion is you start having conversations with the nurses that you're working with when you go to the ICU. What kind of problems do you have? Catheter-associated urinary tract infections, ventilator-associated pneumonia. Those are like big ones, but I mean there's a lot of other things. Infections are often common. Sky's the limit. The kicker with this is all you need is 3 research articles. It's astounding how much trouble we have trying to find what's an actual research article. So when you look at your clinical schedule or this course calendar, you'll see that there are little deadlines, kind of soft deadlines. So you have to have your article, your topic is due to your clinical faculty by this week, and then your articles are due by this week, and so on and so forth. That helps you keep on track. Okay. At the very end of the semester, I think it's the last week of class before the final, y'all will present your posters to the group. Okay? So if you have a 72 or greater on as your final average, so 71.5 or greater, once all grades are in, and you participated in this, and you are in attendance, again, we'll go over this more as we go forward, on the day of posters, you are eligible up to 2.5 points on top of your final grade. So for some of you, this could be the difference between a B and a C, or an A and a B. Okay, so if you have a 78, it'll take you up to an 80.5. Okay, so we'll do more on this later. Don't talk to people before you, though, because in the past we would let them do a PowerPoint or a handout or something else. You actually have to create and submit a real poster, whether it be on a trifold or you can get them printed out from IT, okay, on their templates, things like that. So talk to your faculty, your clinical faculty, or you can talk to me about how that works. But you actually have to have a poster. Okay. What else is here? Clinical assignments. So clinical information is where you'll find your faculty's all of their documentation. If it's in there, I do not suggest looking in there because I haven't updated anything and I can't say that anybody else has updated anything. So don't start looking at stuff, printing stuff out, if you can even see it, because it may not be current. That's where rotation schedules and such will be. Clinical assignments is where you're going to submit all of your clinical paperwork, your homework. I have it, you're not going to be able, you can see what mine looks like. So I have it by weeks of the semester. This is something that people had requested last semester, is to actually have it by week of the semester. So week 1 is now. Okay, probably nobody has anything you need to put in there. So don't worry about it, ignore it. Some people, some faculty like to have exchange of documents, and I thought that this would be a good way to have that there. So don't worry about it. But each, I mean, you can see how this, it's going to roll out each week. Okay, so Monday at noon, as a general rule, is when things are due for this course. Okay, if you have stuff that's due, you know, if you have classroom assignments, if you have anything else, it's going to be due at Monday at noon. So clinical paperwork is going to be time-stamped late if it's not submitted by Monday at noon. Okay, if your clinical faculty tells you that Tuesday at noon is fine, that's between you and them, but it's just so you know it's going to be time-stamped late. But it will roll out as the semester goes by. Okay, and we'll stop there. Current slide. Okay, required resources for this course is Ekg. You already have Ekg. You already have a relationship with Ekg. That's what we're going to continue to use. Okay. And that is the only required resource that we have for this, for y'all for this semester. I have a question for y'all though. How many of you all used Evolve case studies for Adult 1, correct? How, do y'all still have access to that, or did you just buy a 1-year thing, or did you buy a 2-year thing when you bought it? Okay, if you have 2-year subscription to that, raise your hand. Is that everybody? Okay, all right. We are not going to require you to do case studies or anything this semester, but we may choose to assign clinical makeup work from Evolve. That's why I'm asking, to figure out if that's even an option. In the past, we required case studies and practice questions to be done, but that is not going to happen this semester. So your only required resource is this. You obviously need to have some sort of drug reference book or guide or app or something. Okay, but this is the only thing that you need. Attendance policies, you're adults. We prefer that you came to class. We do use Integrity in this course. Okay, we also understand that life happens, and you might have kids or a job, or you may be sick, or you have to be, you know, whatever. For exams, the exam policy is the same as any other course. Contact preferably myself before the start of the exam. And then if you then have documentation like from a physician or something, that'll come to me for the exams. If it's a clinical absence, those will go to your clinical faculty. Or if you have an adjunct, it'll go to your full-time faculty that's covering, but we can go over that more later. Okay. For clinical, y'all remember that you have that one freebie if you have one unexcused clinical absence, but that up to 2 clinical absences, we say, could result in clinical failure, because that's 14 hours of clinical that you've just missed, and you may not be able to make that up. Okay, so we get a week for spring break this semester, so that's kind of can be your mental health week of nothing. You know, somebody always comes down with a med-surg flu. Like, if I have to go to the med-surg unit one more time, I'm going to die, so I'm just not going to show up. But you only get one of those. So then if you get sick for real and you have to miss, then you've just missed another day, and so you're kind of in trouble. So y'all just be careful. Y'all are adults. You can handle that. Do y'all know that your private Facebook groups, we know what's going on in there? Y'all know that by now, right? So when you talk about test questions, or you talk about us, or you talk about whatever it is that you're talking about that you probably shouldn't be talking about, we still get screenshots and we know what's going on. So just be careful with what you do and what you say and all of those kinds of things. Email, y'all need to be checking your email. If y'all haven't figured that out yet, we rely heavily on email, and y'all just need to check it. We do use Integrity in this course. We've already gone over this. What we're going to do in this course also is we're going to ask you to sign a confidentiality agreement. This is basically you saying that I understand that what goes on, that what we have like items on the test don't go anywhere. Okay, you don't get to talk about in the hallway, you don't get to talk about it on Facebook. You can talk about it at home with your husband or your spouse or your kids if you torture them that way, that's fine. But y'all just need to be careful with what y'all talk about. Same with clinical stuff, things with faculty. We, as faculty, will abide by this as well. Okay, so if we have a conversation with you in clinical, that will be between you and us. It's not going to go anywhere else. Okay. This is going to be something that y'all are going to address through Blackboard, through this classroom assignments. It's these two things. It's confidentiality agreement. It's going to be a I understand or I don't understand. Okay? Excuse me. So basically you just need to read this and you need to say I understand. Yes. Okay? And then the same with the policy on clinical grading. You're not going to sign that first sheet. I don't know if y'all have done that or if most courses are doing it this way. We're not going to gather any papers saying that you understand how you're going to be graded. You're going to go into this and you're going to say, I get how I'm going to be graded. And you're going to same thing. You're going to say, yeah, I got it. I've read it. I understand how I'm going to be evaluated. You click it yes, and then you're done. Okay. Those two items are going to be considered your ticket to the first exam, and we'll talk more about that later. But all you have to do, you can leave here now, today, you can do, whatever. Just go in and make sure that those two things are done, and it'll show up as a checkbook in our grade book, and then we know that you've done what you're supposed to do. Okay. You have 3 exams. Exam 1 is worth 20%. The rest of them are worth 25%. You do have a comprehensive final in this course. The remaining 5% is going to come from your med-surg HESI. Because the med-surg HESI is a standardized test that we do not build, we do not get to pick what is on it, it is only worth 5%. Okay? Some people are already mad about this. You don't need to be mad about it until April, because that's when it'll be. Okay? But it'll be 5% of your overall score, and it's that conversion score. So you know how you get your numerical score, and then it converts it to like an 85 or a 99.99 or whatever it is that you get. Okay, so that is what will go into your final computation of your grade. Exam 1, since it's only 20%, but that gives y'all an idea. It makes it way less so that you have a chance to see what our tests are like. Okay. Exam review is immediately following the test. We are not going to lecture at you after the tests. Exam review is optional. But then if you want to turn around and review your test with your faculty, if you don't come, then you can't review your test with your faculty unless you've not scored a 72 or greater. Okay. So group review, basically how test is going to go is everybody's going to sit, they're going to take their tests. I'm going to go, I'm going to run your Scantrons, I'm going to pull down the statistics on the test, I'm going to find the most frequently missed items, I'm going to come down here and I'm going to do kind of what we did in pharmacology, and we're going to go through the dot cam, and we're going to go over all the questions. The kicker with this, though, and it's going to frustrate the tar out of some of y'all, is we're not going to go over every single one. And you're going to say, man, I wish I could see every single question. We only have enough time to go over the most frequently missed questions. We're going to give y'all a piece of paper, a half of a piece of paper, where you can write us notes. You can write us love notes. You can write yourself notes. You can play hangman. You can draw. You can do whatever you want, but your name is going to be on that, and you're going to turn it in. And that's your role. Okay. So it'll be a guided review of selected items. Individual review may be requested if the group review is attended. I get that group test review is going to send some of y'all into like a hypertensive crisis, okay? Y'all are just going to have to work that out. You can come talk to me if you need to. We don't need to have any strokes here, but individual review, if you did not fail the test, you can still request the test review, but understand that we're going to have to prioritize appointments based on need, okay? If your test score is 72 or lower, you do need to meet with your clinical or full-time faculty to go over it. And it has to be done within 2 weeks of the exam. So you can't, before exam 4, come in and say, I'd like to review exams 1, 2, and 3, please. So we will start, if not everybody has taken the test, then the 2-week period of time will start once everybody has tested. Okay, so it's not a hard 2 weeks after that test. We can shift it up and down if we need to. Adjunct students will meet with full-time faculty. We've already talked about this. Optional with your clinical group, worth up to 2.5 points on your final grade. You have to create a poster, and you have to be in attendance on the day. So one of the most frequently asked questions, which you're going to ask again because you're not going to remember, but I'm going to say it anyway. Not everybody in the group has to speak. So if you would rather be pecked to death by chickens than stand in front of anybody and talk, then you just have to show up, okay? And somebody in your group who likes to talk to people can be the ones that stand up here, okay? So y'all are going to work that out. But no, you don't all have to actually speak. Everybody needs to participate in it. And it's 5 minutes. And I like to torture y'all because I make y'all use the microphone. Okay, stuff that's not in your grade but you have to do anyway. So we've got the math test. You know about that. I've told you about the pharmacology test already. Clinical paperwork is going to be determined by your clinical faculty, so I'm not going to talk about that too much. They will talk to you about your expectations, what they require, all that kind of stuff. Simulation prep work. So that's going to be your first assignment that's due for the courses is in week 3. You will have Code Blue simulation, and there will be prep work for that. I think it's set to open today, but I'll double check so that y'all can get working on that early for people who like to be ahead of the game. Everybody, with the exception of Miss Sheldon's Saturday group and the VA group, will be on your normal clinical day. I will send out an email specifically to you people that I just mentioned to tell you when you will be. Okay, but everybody else is going to be on the normal clinical day. Okay, but yes, the schedule will be up at some point in time. Okay, y'all don't forget your bloodborne pathogen coverage. We've discovered that as juniors, junior 1, junior 2, you're really good about going in and registering and printing out that little thing and keeping it in your wallet, and that's all good. And then come senior 1, nobody cares anymore because you're tired and you just want to be done. Okay. So after the census day, which I can't remember what the date is anymore off the top of my head, but after the census day, you can go in and you actually need to re-register for your bloodborne pathogen coverage, and you have to reprint out the card. Don't try to do it today because you're not going to be able to because we haven't gone through the census day yet. People are still, late registration is open until Friday. So people are still going to be registering and dropping and registering and dropping up until then. But you do need to have this. You do need to re-enroll in it every semester, and you do need to have it with you on your body while you are at clinical. Oh, there it is. Look, 131. Okay, immunizations, you're done. CPR should be already done, otherwise you wouldn't be in the class. Just remember that if your facility requires modules or whatever kind of paperwork your clinical facility requires, you have to get it done by the time that either your clinical instructor or your clinical facility requires it to be done, or you cannot go to clinical. Like, we can't make exceptions for that. That's not us being bad guys. That's us trying to follow the rules and get in line and march in the right direction, okay? So if y'all haven't been checking your emails and you have stuff in there that's time sensitive from your clinical faculty, you need to prioritize that high up there. You can't let it get to the bottom of the pile, or you're not going to be able to go and you're going to have to drop the course. Okay. Y'all remember that if you do not turn in your stuff on time, we can give you a not met on your clinical evaluation tool. Clinical policies you will get from your clinical faculty. Okay. So,
Okay, let's make sure this works. Well, let's do this. Okay, so what I'm going to do is go over some terms with you, and you've got to have an understanding of this stuff. When you're dealing with EKG rhythms and interpreting EKG rhythms, all that you're dealing with is just electricity. It tells you nothing. Zero. Tells you nothing about the mechanical issues of what's going on with the heart. I can't look at an EKG and say, well, your cardiac output is this much. It doesn't tell you anything about the physical properties. All it tells you is where electrically the impulse started. And it's sort of like an automobile. If your battery may be okay, but if you don't have enough fuel in the fuel tank, your car's not going to start, or it's not going to run. So, same principle with your heart. I mean, you can have a good electrical, nice wave pattern, but you may not have the associated mechanical aspects that go along with the electrical part of it. So, but we assume that people are doing okay because you walk in the room and, they're warm, they're talking to you, and you look at the EKG, and based on what you see, they're alive. There can be circumstances where you have EKG activity and no life. And you go, how does that work out? Well, that's what they call PEA and pulseless electrical activity. So that's sort of, that's the bad side. You need a pulse. You need a blood pressure. So, so that's, that's basically to start this thing off. Now, the other thing that you're going to do when I go through this information with you is you're going to learn this information either by inductive or deductive reasoning. And what I mean by that is with inductive reasoning, for each of the rhythms I talk about, I'm going to give you specific criteria on why that rhythm is the way it is. Okay? You can argue with me, but what it is, it is. So inductive reasoning is you learn it based upon the criteria that I give you for each rhythm that we talk about. Deductive reasoning is where you got all this information about different rhythms, and you sort of go through the forest and you go, well, because Neil said the rate is this fast, I can eliminate all the ones I talked about that was a slow rhythm. Or because Neil said that this rhythm's irregular and this rhythm is regular, when I march it out and measure, then I could get rid of everything that Neil said is irregular. So what basically happens is you narrow it down just by eliminating those that you say, well, it can't be this because the rate's too fast, or it can't be this because there's more than one P wave, or the PR interval's not right, so I can eliminate all this. If you got a normal PR interval and one P for each Qrs complex, you can eliminate every junctional rhythm, you can eliminate every heart block that I told you about, and just narrow it down. So deductive reasoning is you're going to come to your answer by getting rid of all the extraneous ones we talk about. And inductive reasoning is I know exactly what the criteria is, so it has to be this. So this is the way you're going to learn this stuff. Okay? And I know that you'll learn it and memorize it and be done with it after the first test, but it's going to come back at you. because number one, it's going to be back on the final. And the other thing is you're going to see it in the clinical areas, and you're going to want to know what is going on with your patient. You're going to put all the pieces together on why the patient looks like crap laying in the bed associated with this specific rhythm. Okay? Now, let's talk about the patient looks like crap. Okay, how do you look like that? Well, number one, you get old, okay? And you carry a lot of baggage with you. Not just this up front, but I'm talking about things in your life, diseases and, diabetes and a little bit of heart failure once in a while and, a good MI and maybe a gallbladder attack and, all these things that come with you, in addition to the reason why you're laying in the ICU for another reason, okay? So, looking like crap comes on two ends of this perspective. If your heart rate is 30, no matter where it's coming from, and I got a heart rate of 250, the patient is clinically going to look the same. All right? Signs and symptoms of decreased cardiac output. From a rate of 30, you're just not squeezing enough blood out to the different areas that need it, like your whole body. From the standpoint of a heart rate of 250 going very fast, you're also going to have low cardiac output because you're not allowing for adequate filling time. Okay? The heart's got to rest, fill up, but if I'm clocking away at 250, I'm going to have just as little output as someone who's got a rate of 30. So the treatment's going to be totally different. Okay? So what do you look like when you've got heart rates like this? Well, it's going to be very organ specific, not like the specific ocean. Okay? It's going to be, I got no output, so my head, think of neuro issues, level of consciousness, that's the big thing, all right? From a lung standpoint, not enough blood going by, you're going to be a little bit hypoxic, short of breath, real apprehensive, okay? Air hunger, okay? You're breathing faster, okay? From a kidney standpoint, a little bit of a late sign, but no PP in the Foley catheter bag. Forget about urine output, okay? It's just not going to happen. Your bowels, don't expect them to have this terrific bowel movement because you're not going to have enough blood supply and you'll end up with an ileus or some kind of clogged bowel, okay? Your pulses, forget it. You're not going to be able to feel them. They're going to be very diminished. Skin, cool, clammy, color, basically like my shirt or my pants if you wait way too long, okay? Blood pressure, don't even look for one because you're not going to have one at those two rates. And, every organ, every part of you is going to be affected if I don't give you enough blood supply, okay? So let's go over some of this terminology, okay? All right, automaticity. Let me start drawing and show you what's going on here. Okay, if I were to take one cardiac cell, this is just one of millions that you got, okay? What happens is the heart is very unique because if I come in there and rip your heart out, take it out, and I stick it right here, all right, it's got a mind of its own. It's going to keep beating. But if I took some of your muscles and ripped out your biceps, it would just stand there and do absolutely nothing. Because electrically or neurologically, your head has to control and tell your body, I'm going to pick this up, I'm going to, the actin and myosin start doing their thing, and there's a physical part that you've got to do. I don't have to do anything electrically. The heart's going to beat on its own. So that's a tremendous difference in what's different with the muscles out here versus your heart. Okay? So the term excitability or automaticity is this right here. You go, the inside of the cell is more negative and the outside is more positive. This is what it is in your cardiac cell. Okay? This is what's referred to as the resting phase. So this is resting, and this is, I'll just say this is the active phase, electrically. Okay? If you want to also put terms on this, I didn't want to do that yet, sorry. Okay. If you also want to put this is the period of time where the cell is repolarized. And this is the time where it's depolarized. This is electrical, just electrical. If you want to superimpose what you think, what's going to happen physically to the heart during this time period, this would be what's referred to as, diastole, okay? So that's the resting phase. This is physical property right here. This is physical, okay? If you want to apply the term. And this right here is systole. Systole. And again, these are if you want to put a name to it. So what's happening is during this time period of the cardiac cycle, okay, you have certain areas in your heart which are called pacemaker sites. And they go off and do their own thing automatically, and they set the tempo. Okay? And what that's referred to is the intrinsic rate. So these are terms I'm going to throw at you. So intrinsic rates, meaning that certain parts of the heart automatically beat at a certain time period, at a certain rate. And it's intrinsic to that area. That's what this area does. So intrinsically, the SA node normally beats at a rate of 60 to 100. Okay? Intrinsically, the AV node beats at a rate of 40 to 60. Intrinsically, the ventricles will beat on their own at rates of less than 40. So what you see here is you can have areas of the heart, you can have rates going at different parts of the heart, but how do you identify, if I can have a rate of 60 coming from the AV node, and I could have the same rate of 60 coming from the SA node. How do you determine what it is? Well, that's what we're going to try and go over in the next hour and a half and talk to you about that. Okay? So if you look at the pattern of what is affected on the EKG portion related to your heart, from the SA node through the AV node up to the ventricles, you're dealing with the P wave and the PR interval. We'll get over that, and we'll get into that in a minute. All of the ventricles deal with the Qrs complex. So any beats that arise or problematic above the ventricles are going to have an effect on the way the P wave looks, or how long or normal looking the PR interval is. So the P and the PR interval are specific to those areas of the heart above the ventricles. Okay? The Qrs complex deals strictly with ventricular activity. You also have the presence of a T wave. Okay? The T wave represents, we're going to get into what that is as well, but the T wave is a part of this as well. Okay? And the T wave represents ventricular repolarization. Okay? So repolarization occurs in both the atria and the ventricle. This is where you are. Okay? Now, I'm going to draw something for you. Don't panic. Don't close your eyes. It's not Halloween. It's not that bad. Okay? I'm going to draw you an axial potential. Okay? All right? Here's what an axial potential looks like. Just like this. That is an axial potential. And if I were to transpose what this looks like on an axial potential, I'm going to do this. This is going to be minus 90 over here. This is going to be minus 60. This is going to be plus 10. Okay? And then the same thing is going to be on this side, except up here, what's happening up here is the cell is in this condition right here. If I were to draw the cell over here, it's like this. Okay? Once you get the transmission of the sodium-potassium exchange and a little bit of magnesium and calcium, once you get that change that occurs within the cell, it starts to depolarize. It becomes less negative and more positive on the inside. Okay? This minus 60 is very important. It's an all or nothing phenomenon. You're either pregnant or not pregnant. Okay? It either fires or it doesn't fire. Okay? So once the inside of the cell changes its electrical properties to at least a minus 60, the cell is going to fire and do this right here, wherever it is. Okay? So this thing starts going like this. It's a little bit, and then when it finally gets up here, it's a plus. And when it finally gets over here, it's all the way a plus, like this. And then when it starts getting back to normal, it starts mixing itself up a little bit. Negative, positive, positive, negative, negative, positive, positive, negative. And then when it finally gets to this point, okay, it's back to here, and it's ready to fire again. Okay? Very important for you to understand this concept. Extremely important for you to understand this concept. Because whatever part of the heart it is, whenever that part of the heart is in this condition, more positive inside, more negative outside, you will not have any abnormal beats. Electrically, you cannot accept an impulse until the cell is back to a resting state. Okay? Electrically, it's not going to happen. Okay? Very important for you to understand that. Okay? So okay. So automaticity is the ability of every cell in your heart, wherever it is. You hope it initiates here. Okay? But if it doesn't initiate here and you get abnormal beats outside the normal pathway, then it occurred because the cells in that area of the heart were electrically ready to accept an impulse, or they were ready to party on their own. And they weren't going to wait for these special areas to initiate the complex and make the electricity go down. Okay? So automaticity, the definition of that is the ability of cardiac cells to initiate an axial potential. And I just drew that for you. That's an axial potential. Don't be scared by it. Okay? Excitability. Excitability is the ability of cardiac cells to get excited. When one cell, what happens is they're all together like this. They're all buddy-buddy right next to one another. So what happens is once one cell communicates to the other, or it starts the process, you know, where it starts to depolarize, okay, it'll go all the way across. The wave of depolarization occurs in this direction, from the top of your heart down, like this. That's the way it should go, okay? So excitability is the ability of cardiac cells to become excited. Now, when would that not occur? Okay? Well, if I have a nice heart attack and blow out a portion of my myocardium, that part of the heart may be completely dead. So that may not respond electrically to that, but the impulses will go around that area and continue to depolarize, hopefully in a normal fashion. Okay? Now, if it occurs in the ventricles, let's say where most MIs occur. I mean, you blow out your left ventricle because it works the hardest. So if you blow this area out over here, or you got some kind of hypokinesis where there's very little movement in that area, you can just about assume that the cells in that area just aren't going to respond very well. So electrically, when the wave of depolarization occurs, it'll go a different route around that to depolarize the cells. Well, the more area you got killed off down here, the wider your Qrs complex is going to be. We'll get into normals in a minute. But if it takes a longer period of time to go through the ventricles, then your Qrs is going to be longer electrically because it took a different pathway. Okay? And I'll get into the correct terminology with you soon. Conductivity. Conductivity is the ability of cardiac cells to transmit an impulse from one cell to another. Okay? So if you look at automaticity, excitability, and conductivity, okay, those are all electrical properties I just talked about. The only one that's a physical property is the contractility. Contractility is the ability of cardiac cells to shorten in length. The ability of cardiac cells to shorten in length for a given set of loading conditions. The ability of cardiac cells to shorten in length for a given set of loading conditions. And in parentheses, behind loading conditions, I want you to put preload and afterload. Okay? Contractility, the ability of cardiac cells to shorten in length for a given set of loading conditions. Parentheses, preload and afterload. Preload is volume. You have volume on the right side of your heart. You've got volume on the left side of your heart. It's what your periphery throws into your right atrium. It's what your, on the left side, it's what your lungs and the blood flow from there throws into your left atrium. So you have preload on both sides. Okay? Afterload. Afterload is resistance to flow. Afterload. Resistance to flow. Okay. Resistance to flow is the competency of your heart valves. If your heart valves are real stenotic, that's going to make it a lot harder for blood to push through that area. Okay? If you've got hypertrophied ventricles, a stiff heart, which has no compliance, it doesn't give it all, and it's just stiff, and it's big and fat, and it doesn't move, that's going to be a problem with your afterload. Okay? If you've got real bad pulmonary hypertension, that's going to be a big problem with afterload. Resistance to flow. When blood goes to your heart, when blood goes to your lungs, it's going to be harder for it to get oxygenated. Okay? Blood pressure out here, that's left-sided. That's resistance to flow. The higher your blood pressure is, the greater your heart has to work against to push blood forward. So these are some examples of differences between preload is volume, afterload, resistance to flow. Okay? All right. I talked about inductive, deductive reasoning, and you're going to absolutely have to follow a pattern when you look at that. All right, so how does it start? First thing is axe potential. Wrote that on the board here. Okay? So don't be afraid of this. This is an axe potential, one cell. Okay? So that's the axe potential. All right, terms to know. Depolarization is when this occurs. When the inside of the cell is more positive and the outside is more negative, that's depolarized. Repolarization is when the cell is ready to accept an impulse and the inside's more negative, the outside's more positive. It sounds kind of crazy, you know. It sounds backwards, but this is the way it is, okay? So again, depolarization is here. Repolarization is readiness to accept another impulse. Okay? So where it starts is it starts in your essay note. What happens is the rate of your essay node overrides the impulses that may be occurring here. Okay? So if you're going at this rate up here at 60 to 100, you should never have to wake up these areas of your heart. These areas of your heart should never wake up. They're there for your protection. Because let's say a higher pacemaker fails. Let's say I drop down or I lose this ability, the SA node gets blown out for some reason. You better hope the AV node fires at its own intrinsic rate. And sometimes it'll go even faster to try to compensate. And we'll talk about terminology and what the rhythm looks like. And if this fails, you better hope the ventricle kicks in at its own intrinsic rate. And the complexes are going to look a whole lot different. Okay? So what happens is once in a while, the heart will, if you slow down, let's say you go to a rate of 48, you vagal down. You may wake up this area and have an abnormal beat or an abnormal rhythm until you go and punch the guy in the gut or you go yank the Foley. Oh, God. Did I just tell you to do that? Okay. Why are we yanking the Foley? Okay. Any type of pain is going to give you the sympathetic response to get you for your heart rate to get back in gear. And it will wake up the upper part of your heart if it's still functioning. Okay? So, that's Neil's saying around here, is yank the Foley. Okay? It gives you time. All right? Because you're not going to be super nurse and open up your cloak and have all these magical drugs and things to do something. It works. We can take care of the bleeding later. Don't worry about it, okay? We want a heart rhythm. We want a pulse with that, all right? Okay? This is critical thinking. You will not find that in your textbook, okay? And I did try to write questions related to that, but they wouldn't let me, okay? It's the truth. Okay. Okay. All right. Refractory period. Very important for you to understand this. You got two types of the refractory period. You got the absolute refractory period and the relative refractory period. Absolute refractory period. Absolute refractory period is this. No matter how hard an impulse tries to go in or stimulate that part of the heart, it ain't going to do it. Because electrically, the heart's that part of the heart, the cells, is depolarized. So absolute refractory period is that no matter how hard an impulse wants to come in from outside the normal pathway, it's not going to let it happen. That's absolute. Okay? It's more important with the ventricle, and we'll get into that in a minute. Relative refractory period is when you're over here. This is relative refractory period. Over here. Oh. This period of time in here is relative refractory period. Relative refractory period is when the cell is hemming and hawing. It's neither repolarized completely or depolarized completely. It's sort of in the middle. It's getting itself back together again to accept an impulse. But relative refractory period is that the cells are so disorganized now that there may be some that accept an impulse. Okay? If the impulse is hard enough in that area of the heart, it may stimulate that part of the heart. That's what's meant by relative. Absolute, you can't stimulate the part of the heart because the cells are like this. Relative refractory period, they're mixed and matched and they're turning themselves around. And with a strong enough impulse, it'll stimulate that part of the heart. That's the difference between the terminology. Okay? Please stop me if you have any questions. This is all normal stuff. You've got to understand the normal before we even dive into the abnormal. Okay? And then memorize the components of the normal EKG complex. Now let's talk business here. Okay, here is a oh, the back. Okay. Okay. All right, so here is a QRS complex and a T wave. TP. Okay. So if we look at the QRS complex, or what a normal one looks like, the first thing that you see happen is the initiation of the atrium. Okay? That is represented by a P wave. Okay? I don't know where they came up with these letters. It wasn't Dr. P. Usually they name things after people, after physicians, but I guess I like that letter, so it's a P wave. All right? We can really screw you up badly and just say that's a A wave or a D wave, but it's a P wave. Okay? P wave. P wave represents atrial. P wave represents atrial depolarization. Okay? P wave represents atrial depolarization. P waves are usually symmetrical. They're as round as they are, you know, the beginning. I didn't quite draw this one the way I should, but it's very symmetrical. The rise and the fall is pretty equal. Okay? Now, just for teaching purposes, P waves can come in different varieties. You can have P waves that look peaked and tall. You can have P waves that look biphasic, where they're below and above the line, like that. You can have P waves that have little humps in it like this. Okay? All this means different stuff. I really don't want to go into it with you. But I just want you to know that P waves do look differently at times. Okay? So that's what a P wave looks like. Represents activity in the atrium starting from the SA node. Okay? That's the P wave. The QRS complex, we'll talk about the complexes first, represents this right here. The QRS complex represents ventricular depolarization. And this happens in nanoseconds. The impulse that starts up top works its way down to your ventricle in nanoseconds. Don't even have to think about it. It's already done. You've had 5 heartbeats, and if I get closer to you like this, I probably just raised your pulse by 10 beats, like this. See? Okay? All right? So I just raised your heartbeat nanoseconds, double it. All right, so QRS complex represents ventricular depolarization. The QRS complex can take on different looks as well. You can have QRS complexes where it starts up and then down like this, or you can have biphasic QRS complexes where it's as much above and below the line, or it could start down first and then work its way up like this. So it just depends on the individual's, yeah, question?
Considered normal variations?
Normal variations.
Like if you were to look at it, it looks like that, would it be a problem, or is that just?
It would not be a problem as long as there's an associated P wave with it. Yeah, it's not really. It could be just a conduction problem. Sure, you can put whatever you wish there. Okay, so it could be, a normal conduction problem. The interval of time is what's important. The normal is about, we haven't gone over this yet, but the normal QRS interval is about 0.05 to 0.11 seconds. But I'm just going to say no greater than 3 small boxes. 0.12. That's from the beginning of the QRS. From this point here to this point here, this period of time should not be any greater than 3 small boxes. We'll get into the boxes in a minute. I'm just going over the waveforms. Okay? All right. Then you have this period of time here. This is what's referred to as the ST segment. Okay? When people are having an MI, or they've got chest pain, or they got issues with pericarditis or some kind of inflammation, that part of the EKG is going to be elevated more than usual. Okay? The T wave. The T wave represents ventricular repolarization. So now we're back to this state in the ventricles. So the waveforms I gave you was the P wave represents atrial depolarization. The QRS complex represents ventricular depolarization. The T wave represents ventricular repolarization. So electrically, what don't you see on the EKG? You don't see atrial repolarization, but it occurs somewhere in here. And the reason why you don't see it is because the ventricle is such a big muscle mass that it overrides whatever blip the little atrium would do for you. But if you were to take an electrode and just stick it right in the atrium during that period of time, you would see some kind of representation electrically that the atrial is ready to fire again. But you don't see it because it's too overwhelming. You hope it occurs because the next EKG complex needs to come. So then you get the P, QRS, and T again, okay, like this. What you'll notice is that premature beats that occur within either from the atrium, the AV node, or the ventricles. Premature beats. Premature beats means it's an unexpected beat that occurs before the next one. So your premature beats that occur always occur between this and the next thing here, because it's during this time period where the heart is ready to accept an impulse. During this time period, both the atria and the ventricle are in this state. So anyone can have a party. Okay? Anyone, anything in this heart can go ahead and say, I want to go ahead and have fun and deliver you a premature beat, because electrically, the heart's ready to accept an impulse. Now, why do I keep going? I keep playing with this stupid button. Put this down. Okay. All right. So the PR interval. Let's talk about the PR interval. The PR interval is the measurement of the PR intervals from the, write this down, and then you'll get confused, and then I'm going to explain it. Okay? PR interval. The PR interval is measured from the beginning of the P wave, PR interval, the beginning of the P wave to the beginning of the first negative or positive deflection. Okay? PR interval. PR interval is measured from the beginning of the P wave to the beginning of the first negative or positive deflection off of the isoelectric line. I'm going to explain it. I promise you. So PR interval, the beginning of the P wave to the beginning of the first negative or positive deflection off of the isoelectric line. Let me show you where the isoelectric line is. Base, it's called, see this when it comes back to here? That's the isoelectric line. That's baseline. So the PR interval is from the beginning over here to the beginning of the first negative or positive deflection off of the isoelectric line. Remember, not every QRS is going to look just like that. I'm going to have QRSs that take off down or they take off up. So it's whichever way the QRS takes off of is where you're going to stop the measurement. Okay? The PR interval represents that period of time. How long does it take for the impulse? Oh my God. How long does it take for the impulse that arises up in the SA node to depolarize through the atrium, through the AV node, up to the ventricles? That's the length of time I'm talking about. So it's from the top, through the atria, through the AV node, up to the point when the ventricles start. That period of time should be 0.12 to 0.20 seconds. If you look at EKG paper, let's talk about EKG paper, 0.12 to 0.20 seconds. That's the length of time for a PR interval. Each one of these little boxes represents 0.04 seconds. On EKG paper, there's 5 small boxes, and then there's like a dark line, and then it starts over again. So between dark line to dark line is 0.20 seconds. Okay? If you're bored, you can count the number of EKG boxes on a minute of EKG paper. There's 300 large boxes in 1 minute of EKG paper, or 1,500 small boxes. Okay? So each little small box represents 0.04 seconds. Okay? So PR interval should be no greater than one big large box. Okay? Okay. Qrs complex. Basically what that is how long does it take for the impulse that arose up here to now depolarize through the ventricles. I'm giving you a large thing. No more than 3 small boxes. 0.12. If it's greater than 0.12, let's say it's 0.24, but there's P waves in front of it, each one of those beats, all you can tell me is that there's a IVCD, intraventricular conduction delay. Don't label things, oh, that's a bundle branch block pattern, okay? You need a 12 lead EKG to diagnose that. If you're just looking at a single strip and your Qrs complex is longer than 0.12 seconds and you've got P waves in front of it and it's regular, then you've got whatever the underlying rhythm is plus the IVCD. It's not an IUD, okay? It's an IVCD, intraventricular conduction delay. Yes, ma'am.
Are you saying that's for the length of the QR?
That is correct. That is correct. And all that's telling you is that the electricity going through the ventricle is taking a longer period of time to get to the end. Intraventricular conduction delay, IVCD. That's the lingo. But you'll have other people look at it and go, oh, that's a bundle branch block pattern. And I'm going to scream at you and tell you you can't do that. Okay. I told you about the ST segment. Now, the T wave is not quite as symmetrical as the P wave. The T wave, if you look at it, you know, exactly, it ascends faster than it descends. Because sometimes you'll have P's and T's and you won't know which one is where. But if you look at you know, the P's are going to be more symmetrical than the T waves. The T wave ascends faster and descends slower. Okay? That's how it works. Now, this period of time right here, QT interval. I know you're not going to like this, but you got to know it. Okay? QT interval. I'm going to draw two things here, and you're going to tell me what the difference is. I'm going to make it very obvious. So obvious, you're going to laugh at me. Okay? Oh, the back. Okay. So we're going to go here. All right, this is real obvious, okay? This is A. This is B. All right. Do you notice the difference? Okay. The difference being this period of time from the beginning of the QRS to the end of the T wave, the length of time normally is 0.34 to 0.44 seconds. That's the normal. What happens is, remember, I talked about the absolute refractory period. The absolute refractory period of the ventricles is from the onset of the Qrs complex to approximately the middle of the T wave. That is absolute. Absolute. Meaning that electrically, if the ventricle tried to give you a premature beat, it would not be able to do it, because during this time period in the ventricles, the cells are like this. That's absolute refractory period of the ventricles. When you start getting to about the middle of the T wave out, when you start getting toward this end of the T wave, you're now in the relative refractory period. So you got the absolute refractory period of the ventricles to about the middle of the T, and then from the T wave to the baseline is the relative refractory period. This is an important time period for you to understand, because electrically, if the ventricles got irritated and decided to throw a premature ventricular beat at this time, you'll get thrown into VTach and you'll die. or, you know, you'll have torsades de pointe and you'll die. Okay? So that's an important period of time during the ventricles. Why is the QT important? Because what did I tell you you cannot see happen electrically, but it occurs? Atrium. So during this time period, the atrium decide to depolarize, and now they may send another beat down. It may depolarize during this time period, and the complex that comes down may hit during the vulnerable period of the ventricles, and you'll be in polymorphic V-tach. Okay? Prolongation of the QT interval is a result of either severe bradycardia, severe slow heart rate, subarachnoid bleeds, and the primary culprit is the wonderful drugs that we give people, the anti-dysrhythmic drugs that we give them. Because what happens is, if your ventricle is real happy and it's excited and it keeps having a lot of ventricular activity, and you don't want that to come through, if I lengthen your refractory period, your ventricle is not going to be able to stimulate any part of that part of the heart, because if I lengthen this period of time out with drugs, you're going to, it's not, if I lengthen that period of time and you're like this, and parts of your heart want to get excited, they're not going to be able to initiate anything because I made your QT interval longer. And that's what these drugs do. But each one of us has a certain vulnerable period where I can give you drugs, I can lengthen your refractory period, but if you lengthen it out too long, then you could be in trouble. Then you can wake up the ventricles down the line, and you hit during this time period, and you're in cahoots. You're in deep doo-doo. That is a code brown, okay? Not only from your standpoint, but the patient's going to have a code brown as well. Okay? So it's very important that part of your interpretation or your measurements is you measure the QT interval. When I start you on medicine, I would expect to see that QT interval lengthen out. 0.54, 0.60. If you get QT intervals in the 0.8 range, you're looking for trouble. You got to call the doc up and say, hey, have you looked at your QT interval lately? You know, it's negligence on your part if you don't keep up with that as part of your challenges when you look at EKG strips. That's part of your interpretation. Should be. Okay, question over, did I see hands over here or just stretching? Stretching, okay. Okay, so are we happy with this? Anything else that you want to, yes sir?
What should the length of the QT interval be?
0.34 to 0.44 seconds is the normal. So you're looking at 2 large boxes and a small box. But don't panic if it's like 0.5, 0.56. You know, start panicking when you start getting in the 0.7 range, 0.8 range. Okay? The other thing that I want you to know about is how do we count the rhythm? How do we count it? On EKG paper, standard EKG paper, there's these little, I'll call them nibbies. Got no other name to call them. Little nibbies. All EKG paper. You have it? Nibby. Come a little bit. Nibby. Come a little bit. Nibby. They pay these guys lots of money. They live in Switzerland, and all they do all day is they nibby. Nibby. They got paper running out all day. Nibby. Nibby. Those are 3-second intervals. Okay, so when you're counting EKG rates, what you do is find your nibby, and then just count the number of beats between two nibbies and then multiply that by 10. And that's how fast the heart's going. Now, the monitor is going to count every beat that shows up. So if you've got someone with irregular heartbeats or extra heartbeats, it'll count all that as part of the rate. So they may have an underlying rhythm plus abnormal beats. It's going to count it all. Okay? So nibby to nibby is 3-second intervals. Okay? What else you want to know about the nibbies? Nothing? Okay. All righty. Now on there you see what they call a U wave. You don't see it too often, but usually it represents hypokalemia, too little potassium. But sometimes they'll come out on when you got slow heart rates. Real high potassiums, your T waves are going to be sky high. They're going to be peaked. So peak T waves, high potassium, little to no potassium, U waves. Okay? All right. Put that under your pillow tonight. Kick the dog out. It'll absorb. Okay? Okay. All right, 12 lead Ekg, I ain't going there. Your book has a very pretty picture. If you're in your clinical area, we can talk about things, but we're just looking at strip interpretation. That's all. All right? Okay, so what do you got to do? I got to do this first. Okay. So when you're interpreting strips, you have to have a systematic way of doing it. For the first couple of years, I'll give you a couple of years. All right, no eyeballing. I'm sitting right here, every one of your shoulders. I'm on you right now. I'm on you, okay? And what I mean by eyeballing is I don't want you to pick up a strip and go, oh, this is such and such, okay? Because you're not there yet. You got to see 1,000 of them. That's why the monitor techs, they sit there and they know exactly what it is because they've seen it 1,000 times. The nurses will stand in front of the monitor and look, and they know what the rhythm is. They won't need to strip. And it just takes repetition and practice. That's all. But until you feel comfortable enough, let me re-quote that. I'm going to re-quote that. Until Neil feels comfortable enough with you doing the eyeball thing, 2 years minimum, okay? So the first thing in your interpretation of strips is what is the rate, okay? You may have, if there's one P wave associated with each Qrs complex, then the rates are going to be the same. You're not going to have two different rates. But if you got more than one P wave for each Qrs complex, then you got two different rates going on. You have an atrial rate and a ventricular rate. So the first thing you need to do is tell me what is the patient's heart rate. Now you can count the number of Qrs complexes and multiply it by 10. As long as there's one P for each Qrs, the rate's going to be exactly the same. Okay? What is the rhythm? Let me explain to you how rhythm is and how you do rhythm. Okay. Regular rhythm. Okay. You get up every morning at 8 o'clock and you go to the bathroom, either 1 or 2. Every morning, 8 o'clock, 1 or 2. Every morning, 8 o'clock, 1 or 2. That is a regular rhythm. Okay? Regularly irregular. You get up Monday at 8 o'clock and you do 1 or 2, but Tuesday it seems to be 9 o'clock when you do 1 or 2. Okay? Wednesday it's still 9 o'clock. Thursday you're back to 8 o'clock in the morning to do 1 or 2. That is regularly irregular. Maybe every Monday and Wednesday you go at this time, and Tuesday and Thursday you go at another time. But it's that time all the time. Okay? That's regularly irregular. Okay? Irregularly irregular. You don't know what to do because you got to have a bathroom nearby all the time. You can't leave the house. Okay? There's no telling. You could go at 6, you can go at 10, you could go at 11, you can come back and do it 5 in the morning. One Monday is not the same as the next Monday. Who knows when you're going to go? Okay? That's irregularly irregular. Does that make sense to you? All right, so I'm going to see a chart here. You know, Monday, 9 o'clock, went to the bathroom. Okay, hopefully I can do, that's my target date. Get there every Monday at 9. Okay. It's the first thing in nursing school, you figure out where the bathrooms are, right? All right. Okay. That's regularly regular, regularly irregular, irregularly irregular. Got it? So if I have 2 normal beats, abnormal beat, 2 normal beats, abnormal beat, 2 normal beats, abnormal beat, that's regularly irregular. Okay, just keep that in mind. All right, PR interval. You got to measure a PR interval for me. All right, is it within normal limits? Is it less than 0.20 seconds? Is it less than 1 large box? If it is greater than 1 large box, then you got some type of heart block. It's either 1st degree, or it could be 2nd degree, type 1 or 2, or 3rd degree, depending on what your Qrs complex looks like. Okay. So with all 1st degree heart blocks, there's always going to be an underlying rhythm. You absolutely, I will scream at you, you absolutely must give the patient credit for whatever they got going on. So it's whatever their underlying rhythm is plus the heart block. So you can't go, oh, 1st degree heart block. I'll scream at you. It's going to be normal sinus rhythm 1st degree heart block. Sinus bradycardia 1st degree heart block. Sinus arrhythmia 1st degree heart block. Okay? The other heart blocks that you talk about, you know, they're their own rhythms. You know, if you said 2nd degree heart block type 1 Winky Bach, that is the patient's rhythm. Okay? Or if you tell me 3rd degree heart block, that is the patient's rhythm. They're not in sinus Brady 3rd degree heart block. It's 3rd degree heart block. Okay? So 1st degree heart block is the only one of the heart blocks that have an underlying rhythm. You got to give them credit for that. P waves. Are P waves, and this is a yes/no question. Okay? Are P waves present, yes or no? And is there more than 1 P wave for each Qrs complex? That's what you're asking yourself. If there is more than 1 P wave for each Qrs complex, we got a heart block somewhere. Okay? It's usually a higher level heart block. The last thing is the Qrs complex. Is it within normal limits? That's what it's asking you. Okay? Are you happy with this right now? The artwork is understandable. The terminology is understandable. Okay, there'll be more. Now, what I'm going to do is, and what I typically do, is I will describe to you the criteria for the rhythms and then try to show you an example of what the rhythm looks like. Some of them I don't have and I'll draw out for you. But for my test purposes and test questions, you really don't have a chance of getting any. You can argue all you want, but it is what it is. the criteria is what it is. It's very objective information that I'm going to give you. I'm going to either give you a rhythm strip on the exam, and you're going to say, what is this? And I'm going to give you 4 rhythms. Or I'm going to give you the verbiage of what the criteria is for the rhythm, and you're going to tell me what the rhythm strip is. So you're either going to look at the strip and tell me what it is, or you're going to have to know the criteria for the rhythm and know what it is. Okay? There's also going to be some normal questions that I talked about. Normal stuff, repolarization, depolarization, absolute, relative, refractory period. Know some of the terms, okay? You have to know that, all right? I'll give you questions related to, you know, which patient's going to look the worst, and I'll give you these rhythms to look at. Or I'll tell you rhythms and tell me, you know, what do you expect your patient to look like? Well, most of them are going to look like crap, okay? I'm not going to give you a normal rhythm and for you to say, oh, there's nothing wrong with that. I want you to think a little bit, okay? For each, just to clue you in a little bit, the faculty are responsible for writing their own questions. And we got lots and lots of questions, and I always make up some more. So we got plenty in the test bank. The other thing is for each hour of lecture, like my lecture is all period, so I'm responsible for about 15 questions. If the faculty if we split it, then we usually go 7 or 8 on each side. Okay? But if someone's lecturing all day for you, you can expect about 15 questions for that content. Okay? Okay. All right. All right, here we go. We're going to talk about sinus dysrhythmias. So we're going to talk about those dysrhythmias that occur in this area of the heart. Just a few of them, okay? The first thing is sinus bradycardia. The definition of sinus bradycardia is a rhythm that originates from the SA node at a rate usually less than 60, but greater than 40. Sometimes you could be in sinus brady and have rates in the high 30s. But just remember that once you go down slow enough to wake up the AV node, then you may have a premature junctional beat or a junctional rhythm take over. It's called an escape rhythm. You'll hear terms that says, oh, that's an escape beat or an escape rhythm. Escape means a rhythm or beat outside the normal pathway. That's the term, that's the definition I'm going to give you. So if someone says, oh, they had a junctional escape beat, it means that they had a premature beat that occurred outside the normal pathway. Or if it's a rhythm to me is more than 1, 2, or even 3 beats in a row is a rhythm. Now, if the patient's heart rate dips down, sometimes they may be sleeping. Or if they're an athlete, like myself. I saw that. What's her name? I'll take your name down. What's your name? She laughed at me. I don't look like an athlete? Okay. I used to be. I went from athletics to teaching. That's what happens. Okay. So some people are athletic. They can train their heart to extract just limited amounts of oxygen, and their resting pulse may be bradycardic, and they're just fine. Okay. Whereas some patients, you know, don't let the rate fool you, because some patients, if they're used to a heart rate of, let's say, 85, and now they're in a heart rate of 52, okay, doesn't mean, oh, they're fine. You know, they're just sinus brady. That may be clinically symptomatic for that person. Sinus brady, you know, may put someone in where they don't feel good. if they're used to a higher heart rate. Okay? So the lower the heart rate, the less, blood flow you got going out here. Your blood pressure is going to, be representative of that if there's too little flow going forward. Okay? Definitely may have blood pressure issues. Okay? All right. So sinus Brady, you may or may not be clinically symptomatic, depending on how you handle your heart rate. You may or may not wake up the down the line, the AV node, at its own intrinsic rate. Okay. That's about it. If the patient is clinically symptomatic, just, kick them in the hooses or yank their Foley, and just, it gives you some thinking time, okay? It helps them with the cardiac output for a period of time, so you can go ahead and do whatever you need to do to help them, okay? So the rate is less than 60. The rhythm is regular. The PR intervals should be within normal limits, okay? P waves, there's only going to be one P for each QRS. And the Qrs complex should be within normal limits. Should not be a problem. So this is sort of what it looks like. Here's those little nibbies I told you about. See those? Those are 3-second intervals. So if this were a 6-second strip, you would just count 1, 2, 3, 4, 5, 6. A lot of times people would go, oh God, is it sinus breeze, sinus rhythm? If you punch the guy in the gut, maybe his heart rate will go to 66. If you let him sleep a little bit, maybe it'll dip down to 56. So at that moment of time, if you want to say sinus Brady, go ahead. But you can always say, sinus Brady to sinus rhythm. Always give parameters. If you're going to, if it's right on the line, just say, sinus Brady, sinus rhythm between 56 and 64. Just give some criteria a little bit. Okay? That's what that is. All right, Sinus Tach. The way Sinus Tach works is I come up to this person that's eating a cookie. Okay? Do you want to share your cookie with me? Okay. So I come over here and I grab her hand, and she's sweating like a son of a gun. Okay? All right. Do you come here much? You come here much? Okay. You single?
No.
No?
No.
Damn it. Okay. Okay. So, here. So I come up here, and just my presence here, she's getting excited a little bit. I feel it. Okay. Oh, she's clocking away, man. Okay. So the thing about Sinus Tach is there's a reason why it's present. And in this case, it's present because I'm here touching this student. Do you date much? No. Okay. Okay. I'll have to ask my wife if we could get together, but it's okay. Don't worry. So what happens with Sinus Tach is it's usually caused by something. All right. Either she's happy to see me, she's never been approached. And is this the first time ever you've had a man come to you at TWU and put their arms around you and say you're very pretty?
Sure.
See? So that's what happens, is there's a cause for that, okay? Sinus Tach, you better find out what's going on, all right? It's not normal for someone to be laying in bed doing absolutely nothing and clocking away at rates of 120, 130. You better figure it out, okay? Either they're in pain, They are bleeding out somewhere. If you can't see it externally, maybe internally. It could be related to the thyroid. It could be related to electrolyte imbalances. It could be fever. There's something going on. The Foley's clamped off and the urines and their bladder's ready to explode, and you didn't check for kinks. There could be their volume depleted. Okay? There's something going on. You better figure it out. That's your job. Okay? So with Sinus Tach, the rate criteria I'm going to give you is between 100 to 150. Sustained. Now, the bad part about that, though, is sometimes if I ran up and down the stairwell right now, all right, the first thing you need to do is do what? You call the EMTs, and you tell them, Neil's run up and down the stairs. Do you have a little oxygen for Neil? Okay. The other thing is I'm going to need volume. You have to start an IV on me. I'm going to need fluid resuscitation badly. Okay. All right. And I'm going to be very tachycardic. I'll probably be in the 160, 170 range. But once I settle down in about a week, my heart rate will come down to its resting, 60, 70, and all will be good. Okay? So, treat the cause. That's the point I'm trying to make. So Sinus Tach, I can go as high as 160, 170, 180, but with rest or doing something not crazy, it may go back down. If you've got heart rates greater than 150 sustained, it's usually a tachycardia occurring outside the SA node. It's usually atrial in origin. Okay? Usually. So rate criteria, I'm going to give you 100 to 150. The faster the heart rate is, the more this P wave bleeds into the preceding T waves. So it may not stand by itself. Sometimes a real fast heart rate, the P wave bleeds into the preceding T wave, but it's there. You can see some type of, if you look at the whole strip, you could see some type of little ding or it's not quite shaped the way it should be. Okay? The rhythm, regular. PR interval should be within normal limits. P waves present, yes. Qrs Complex should be within normal limits. And this is what Sinus Tach looks like. Okay? So you got P's in front of each Qrs Complex, and the PR intervals within normal limits. If you counted this up, you're looking at a rate of 1, 2, 3, 4, 5, 6, 8, 9, 10, about 14. So the rate there is about 140. Okay? Figure it out. Treat the cause. Okay? Is the patient septic? Volume depleted? Pain? There's a number of different reasons why this may be occurring. Okay? Figure it out. Sinus arrhythmia. Sinus arrhythmia is a respiratory-induced dysrhythmia. It's in young adults like myself. Take her name. What's her name?
Athena. I'll give it to you, Athena.
Oh, Athena. Okay. Usually it's in teenagers or young adults, and it has to do with the pressure gradients intrathoracically. And it is a respiratory-induced dysrhythmia. You breathe in, the rate speeds up. You breathe out, the rate slows down. Okay? Breathe in, breathe out. Breathe in, goes faster. Breathe out, goes slower. It is regularly, if someone is breathing at a rate of 16 and it's occurring that's regular. But if someone is breathing 16, then 24, then back to 22, and I'm talking per minute, and you don't have the pattern, then that's irregular right there. But most of the time, people will be breathing at a regular rhythm. Okay? Speeds up with inspiration, slows down with expiration. Okay? And it's not that hard of a rhythm to identify. The rate is whatever the underlying rhythm rate is. It's usually between 60 to 100. The rhythm is dependent upon your breathing pattern. Okay? It speeds up during inspiration, slows down during expiration. Pure interval, normal. Within, yes, sir.
Is that regularly irregular?
Well, the way I look at it is this, and I don't want to I really don't want to complicate things. But during the inspiratory phase, at every inspiratory phase, it's always regular. During every expiratory phase, it's always going to be regular. But if you put them together, it's going to be irregular because you're going to be measuring R wave to R wave, and all of a sudden this one's going to be longer, and then it's not going to match up. But for the expiratory phase, if you measured the complexes there, it would be regular. But it's only going to be irregular once you take your next breath. All right? This is what it looks like. Notice that during this phase, it speeds up. See, this is a regular pattern here. But if I were to measure R wave to R wave to R wave, the next R wave is longer, but then, it's longer, and then it speeds up again. So these two are regular. That's the expiratory phase. These are the inspiratory phase. But if you look at the whole thing, it's irregular because you're taking a breath. That makes sense? So if you were counting the number of complexes, just count the number of complexes. 1, 2, 3, 4, 5, 6, 7, 8. So 8, the rate's about 80. We're not going to do the 300 method. I'm just simple as can be. Just count the number of complexes in a 6-second strip and multiply by 10. That's it. But notice the pattern. Speeds up, slows down. Speeds up. This is what this looks like. This is going to be over here. Okay? All right, enough said about that. Now we're going to talk about atrial. Just let me erase so I can do some things here. All right. Erase. All right, I got till 11:30. All right, I should be able to get through atrial, and then we'll do some more stuff later. Okay. Okay. All right, let's talk about atrial. All right, atrial, here I'm going to draw it out. Here's P, QRS, T, P, QRS, T. Now I'm going to make it real obvious. Do, 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 do. T, P, T, P, T, P, T, P. And let me do this again. Here's SA. Here's AV. All right, so we're talking about premature atrial contractions that occur in this part of the heart, the atrium. Okay? Let me give you the criteria first. Okay, what happens with a PAC is there's a certain area within the atrium which gets excited for some reason. Usually, premature atrial contractions occur as a result of me coming up there and bothering you, or holding your hand, or kidding around with you. you get a flutter in your chest. Here, let me give you a flutter here. Does it make you flutter when I come like this?
Yeah.
Oh, see? She probably had PAC. I hope they're PACs and not PVCs. Okay? So what happens is PACs are the result of either you're happy to see me, or you're smoking cigarettes, or you're hypoxic. Those are usually the causes. But one of the primary causes that you see is if someone's just hanging around doing nothing, and all of a sudden they start having all these PACs, it's usually one of the first indicators that their heart's being overstretched a little bit more than it wants to be. So it could be an indication that they're going into heart failure, early heart failure. Because the more volume that you have in your chambers, in your atrium when it comes back to fill it, the more you stretch the fibers, the more pissed off they become. Okay? So the more pissed off your fibers become, the more irritated they become, you may have a lot of PACs. So keep that in mind. The other thing that's a trick that these people try to get away with, but you're going to be smart enough, is all of a sudden they get this little cough out of nowhere, you know. They keep clearing their throat on you. Well, you know, if they didn't have a cough before, you know, there's a reason why they're doing that, because sometimes PACs make you cough a little bit. All right, so that's another thing. That's going to cost you about 70 cents. That's above and beyond this lecture content. Okay, all right. I got to make a buck. All right, salaries aren't that great here. All right, no. Okay, so PACs, not to worry about it unless there are a lot of them. Now, what's the criteria for them? Now, I can have a PAC that occurs over here, or I can have a PAC that occurs over here, or I can have a PAC that occurs over here. Which part of the EKG is affected by the PACs? The P and what else? The PR interval. Okay? So on the premature beat, you'll have issues with the P wave, and the PR interval may or may not be affected, and I'm going to explain why in a minute. But following the premature beat, the wave of depolarization should be normal. The problem is not down here. So once you have your premature beat over here, it will depolarize through the AV node, and it should depolarize the ventricles normally. So your QRS in the abnormal beat is going to look normal. The only problem is either with the P wave or the PR interval. Okay? P waves that arise outside the SA node look different than someone arising down here. They take on a different shape. Okay? Okay, that's Dr. Bailey. So P waves look different. So one criteria with a PAC is the P wave in the abnormal beat looks different. I tried to make it look different for you. Obvious. Okay? The other thing that may be different is the PR interval. If you have a PAC that occurs real close to where the SA node occurred, the PR interval may be normal in the abnormal beat because it took just as much time to get down through the AV node. But if you have a PAC that occurs way down in the atria, it takes a shorter period of time to make it through and depolarize the ventricles, so your PR interval may be next to nothing. It may not be within normal limits. So one criteria is your P wave looks different than the P waves that occur in the SA node. The other criteria with PACs is the PR interval may or may not be shorter because of where it arises in the atrium. Okay? Now, underline this, gold star it, whatever you need to do. Okay? Notice what happens after the premature beat. Okay? After the premature beat, the next beat, it's going to not come in on time. Okay? The reason being is the atria have to reset themselves. You have to write this down and put this under your pillow. Whenever the atria have to reset themselves, there's going to be a pause following the abnormal beat. Whenever the atria have to reset themselves, there's going to be a pause following the abnormal beat. This comes into play with abnormal beats that occur in the atrium and the AV node, not in the ventricle. You can scream at me next week about the ventricle if you want. We're not going to get there, though, today. So premature beats that occur above the ventricles have to reset the atria. Thus, the next beat is not going to come in right on time. So following the premature beat above the ventricles, either AV or atrial, okay, it's not going to come in on time. It's not going to be regular. So if you were going from QRS to the premature beat, and then the next beat is going to be not in sync. So if you were measuring from here to here, it would not be the same distance from here to here. This one would be longer. Okay? Whenever the atria have to reset themselves, it's going to be followed by a pause with the premature beat. Okay? Are we happy with this? Okay? Okay. The rate, whatever the patient's underlying rhythm is, plus the premature beat. I will scream at you. Okay? You must give the patient credit for whatever they got going on. You just can't look at the strip and say, oh, he's having PACs. It's not going to fly with me. First, normal sinus rhythm with PACs. Sinus Bradycardia with PACs. Okay? The other thing you can have, let me get some terminology out there, is you can have what they call multifocal PACs. You can have multifocal PJCs. You can have multifocal PVCs. Multifocal meaning that the PACs are occurring in different areas of the atrium. So every abnormal beat that you see coming, it looks different. If it was multifocal, is different areas in that chamber are throwing the premature beats. Multifocal, different areas. Unifocal means that just one area is throwing PACs, and the PAC looks the same every one that you look at. That's unifocal, one foci. Okay? If you have unifocal PACs, that doesn't quite bother me as much as multifocal. Multifocal tells me that you're a little bit more unstable. Okay? If the atria is not real happy with itself, whatever's going on in there. So different areas are firing abnormally. I'd rather just have one area just firing. I'm happy with that. Go ahead, go to town with that. Okay? But if I start in one area and then all of a sudden I start seeing multiple areas, you better figure it out. Okay? Something's going on. Rhythm, whatever the patient's underlying rhythm is, plus the abnormal beat. PR interval, whatever it is on the patient's underlying rhythm, it may be normal or abnormal in the extra beat, depending on where it occurs in the atrium. The closer it is to the SA node, the more normal your PR interval is going to be. If it occurs closer down here, then your PR interval is going to be a whole lot shorter in the abnormal beat. P waves, more than one? No, there's one P for each QRS complex. and the Qrs complex duration should be within normal limits. This is what it looks like here. This is not a great tracing, but here's a normal, normal, normal. Here's an abnormal beat over here, okay? Then you get another one over here. Notice the distance when it starts again. See that? After the premature beat, it has to reset itself. Really need to put a better slide up there. But it'll be easier for you on the exam. You won't have something like this. Okay? So again, see the little nibbies? Nibby, nibby, nibby. These are 6-second strips. If you're going to count the rate, you're going to count everything on there, even the abnormal beats. Okay? All right, atrial flutter. All right. What happens with atrial flutter is now you have what they call flutter waves. They're F waves. Okay? Qrs. F, 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 F. All right, flutter waves. They're not rounded. They're not nice looking P waves like this. They're F waves. They're flutter waves. Okay. Atrial flutter is regular. From flutter wave to flutter wave to flutter wave to flutter wave is regular. F wave to F wave to F wave is regular. It's the R to R. See this? It's the R to R that could be regular and or irregular. And what I mean by that is if it's regular atrial flutter, I can have 4 flutter waves, 1 QRS. 4 flutter waves, 1 QRS. 4 flutter waves, 1 QRS. That's regularly regular. Or I can be irregular ventricular response. I can have 4 flutter waves QRS, 6 flutter waves QRS, 8 flutter waves QRS, back to 4 flutter waves, then 8 flutter waves. It could be very irregular from the ventricular standpoint. But if you were to measure from F wave to F wave to F wave to F wave, that is very regular. Okay? Now, what are we going to do with this patient? Well, if their ventricular response is good enough, they're going to tolerate that. But let's say they got like 7 or 8 flutter waves for each QRS, they're not going to be feeling very well because you need a ventricular contraction to get a little blood going forward. So a lot of times what they'll do is they may cardiovert the person. If it's new onset atrial flutter, then they'll probably cardiovert the person. They'll anticoagulate them, and they'll go ahead and cardiovert them. Okay? Usually the atrial rate could be in the 300 range. Usually it's about 300. It can be 300 to 400. And another rhythm besides this one that's not on here is what I consider atrial tack. Atrial tack is a rhythm where the atrium are now beating at rates of 150 to 250. Okay? That's different than sinus tach. Sinus tach is 100 to 150. But if I give you a strip and you count the rate to be, 210, you can guarantee that it's coming outside the SA node. It's got to be atrial. So atrial tack is 150 to 250. You may not get PR intervals because it may bleed together with it's going so fast, it'll be bleeding into the preceding T waves. So that's another rhythm to be concerned about, is atrial tack. Okay? 150 to 250 is the rate criteria. Okay? So atrial flutter, the rate, you're going to have 2 different rates. You're going to have a flutter rate, which is usually about 300, and then you'll have an R to R to R rate. So the ventricles are usually going to be beating, the ratio is usually about 4 to 1. There may be 4 flutter waves for each QRS, or 2 flutter waves for each QRS. It's in usually even amounts, 2, 4, 6, 8. Who do we appreciate? Okay? So atrial flutter is even, usually in even amounts. Okay? Rhythm could be regular and or irregular depending on what the ventricular response is. PR interval, you can't measure a PR interval. These are flutter waves. No PR to measure. Okay? P waves, they're not P waves, they're flutter waves. Qrs complex should be within normal limits. Here's what it looks like. Okay? That is a regularly regular atrial flutter. Now there's flutter waves that you don't, oh darn it. There's flutter waves that you don't see that are over here, buried in the QRS. You may see it on the bottom over here. But if you were to measure from flutter wave to flutter wave to flutter wave to flutter wave, it's all regular. Atrial flutter is regular. It's the ventricular response to the atrial flutter, which is either regular or irregular, and in this case, it's regular. There's 3 flutter waves that you could see for each QRS. Okay? One more, and then I'm done, okay? Atrial fib. This is a very common dysrhythmia in the elderly, okay? I'm not there yet. God willing. Do you want me to, go? Got a few minutes? Okay. Okay. All right. So I would say that as you get on in years, your battery starts to wear down. Okay? The problem is that you can't go to Sears and Roebuck. They're not doing that great, but and get your battery changed that often, every 4 years. This is a lifetime, your battery is your heart. Okay? And as you overstretch it and you work it, that's why I don't run up and down the stairs too much. I don't want to go into atrial fib. Age gives you this as a reward in most of the population. And what's happening now is the cells are kind of disorganized. They're just plain out tired. They don't want to coordinate activities. They want to be left alone. They don't want to share electrical impulses from one to the other. You know, they're just darn stingy, okay? So what you see in atrial fib is now you see cells, instead of them being in the same like this, getting ready to fire, every cell is doing its own thing. It is so uncoordinated, there's nothing going on, okay? Every cell is doing its own thing. So there's no talking to one another, all right? So you got an atrium which is just doing this. It's not talking to one another. I'm tired, man. I'm 90 years old. All I want to do is this. So what you lose from the atrium, because it does this, is you lose this. This is the squid. Coming to get you, okay? So what happens is you lose this ability, and the heart's just doing this. You lose what they call the atrial kick. It's about 20 to 25%. So your body's kind of neat, because what happens is the valves open up, you pour into whatever chamber, and then you have the physical motion. So 70% of the work is done by gravity, is done just by the pressure, it's a pressure-volume relationship is what it is. And if your valves are in good shape, you'll dump out 70% of your blood into the chamber before it even does this. Well, when you're an atrial fib like this, you ain't got this anymore for the 25%. So you got blood that's just stagnating. Bad news, because stagnating blood leads to clots. And you could develop clots in there and on your valves, and you could flick things off, and you can have strokes. You know, you can throw pulmonary embolism very easily. So atrial fib, you get to buy, you know, Lovenox or Warfarin or that Eliquis or whatever magical drug you see at 2 in the morning on the television for people with atrial fib, okay? You also get to buy an aspirin, all right, because it'll keep your blood a little thinner so it doesn't clump up on you. So atrial fib's not the best thing to have. The way that you manage it is you keep the ventricular response less than 100. Okay? That's what's considered controlled atrial fib. Controlled atrial fib is an atrium that's doing this, like this, with a ventricular response of less than 100. If you've got atrial fib and your ventricular response is greater than 100, that's considered uncontrolled atrial fib. So the goal in treating these people in atrial fib is to try to keep the ventricular response less than 100. Now, sometimes people are in control, they're doing great, and all you got to do is catch the flu, or get a pneumonia, or get come in septic, or something, and it throws your heart out of whack. So now not only are you treating the sepsis, but you're treating someone whose heart rate now is, 160 uncontrolled. So you're going to try to manage that. But a lot of times if you treat the primary cause, the patient's heart rate, if they were controlled before they walked into the hospital, you should certainly be able to get them back in control after they walk in the hospital, unless they've suffered an MI and they blow out more of their myocardium. Okay? So with atrial fib, there's no P waves. It's just an erratic baseline. No P waves. I can't measure PR interval, so there's no PR interval. There is a Qrs complex. The criteria for that is irregular R to R, no identifiable P waves. Irregular R to R, no identifiable P waves. Irregular R to R, no identifiable P waves. And this is what it looks like. So rate is whatever the ventricular response is. Is it less than 100? We're controlled. Is it greater than 100? It's uncontrolled. Okay? Rhythm, very irregular. PR interval, don't have one. I can't measure it. Okay? P waves, no P waves. Can't tell me there's P waves present. Qrs complex should be within normal limits. Here's what it looks like. All right, this first one is uncontrolled atrial fib. Okay? See this wavy baseline, wavy erratic baseline? You really can't see a P wave, but you'll come up to me and you'll scream at me and go, Neil, Neil, I see a P wave right here. And I'm going to go, look at the whole strip. Okay? That's what I'm going to tell you to do, is look at the whole strip. Now, what drives you nuts is because atrial fib is so irregular, you could be in front of the idiot box and look at the rhythm and go, oh, the rate's 65. Now you turn around like this. Oh, my God, now it's 78. Then you turn around like this and you go like this. Oh, God, now it's 84. Well, when you're determining atrial fib, give me a criteria. Give a range is what I'm saying. Say the patient's in controlled atrial fib, rate between 64 and 78. Okay? Because that's what's going to happen, is it'll change on you. And people think you're nuts or giving them wrong information, but you're really not. Okay? So atrial fib, irregular R to R, no identifiable P waves. It's either controlled or uncontrolled. Okay? That's all I got for you for right now. We'll get into paroxysmal next time. Thanks for your attention. All right. You can stop me.